Today we are going to see about digestive system in surgery part. Okay, so they have given a anatomical part of the digestive system. So what are the anatomical part involving in the digestive system? They have given here. So from the mouth to till the anus, they have given. So these are the anatomical parts are involving in the digestive system. So we are going to see one by one. Okay. So first, it is a lip. So lips means these are the anatomical part involving. So um, this is a philtrum, and this is a cupid bow, and this is a vermilion border, and this opening part is the commissure. Then this is a vermilion zone. Then uh, coming to lip, that some congenital abnormalities will be there. Example, this cleft deformity. Um, by birth, they will get this abnormality. So based on that, we will do the procedures of after getting delivery for the newborn. They will do the procedure to correct this cleft palate. Okay, so you can see this is a unilateral cleft lip and this is a bilateral cleft lip. And the inner transverse image of the cleft lip they have given here for the unilateral and bilateral. So they will correct by the surgery, and based on this unilateral or bilateral, it is for a upper lip or lower lip. Based on that, we have to select the CPTs in the surgery part. Okay. Then next to coming to mouth. So mouth means what are the anatomical part involving that one they have given in this image for first gingivae, which means gums. So that scientific name is gingivae. We used to call as a gums. Then this is a superior lip, means upper side of the lip. Then that labial frenulum will be there. That is superior labial frenulum, and this is a inferior labial frenulum. Then this is a hard plate of the mouth, and next one these are the teeth, and this one used to call as a uvula, and palatine tonsil will be there. So here only the tonsils are present for bilaterally. Then this is a oropharynx, and next to the tongue anatomy detailing we will see. Then this is a lingual frenulum. Then this some opening means that glands opening will be there. That is duct of submandibular gland. Okay. Then this is a gingiva. Then inferior labial frenulum, and this is a vestibule of inferior lip. Okay. And this vestibule they have given here. So how it will that upper vestibule and lower vestibule. Okay. Means some inversion will be there. Okay. Then next to that we are going to see about the tongue. So tongue means there is a two part. It is a tip part and base. Other than that, they have given a whatever anatomical or individual place name they have given. So in the tip part, it is a anterior part that used to call as a oral part. It is free and directed forward in a contact with the incisor at rest. Then base means it is a pharyngeal part. Means it is a posterior part, which means that one third of the part. This one, this much only tip part, and this much is the posterior part. Okay, so directed backward towards the oropharynx. Okay, so then other than that tongue part they have given this is the apex of the tongue, and this is a body of the tongue, and one center one line will be there. No, that line name is median sulcus of tongue. Then this is a valate papillae. So this part, some dot structure will be there end of the tongue. Then foliate papillae. This is a foliate papillae side of the tongue. It will be lateral sides. Then root of the tongue. This is one is the root of the tongue, and this is a palatine tonsil. So tonsil is got inflammation means it will get tonsillitis. Okay. Then medial classo-epiclatic fold. This one means that uvula upside that is median clasio-epiglottic fold. Then this is the lateral clasio-epiglottic fold. Then this is a epiglottis. Okay. And next one, palatopharyngeal arc. Then this one, epiglottic vallicula. And this part, lingual tonsil. Then this is a terminal sulcus of the tongue, and this is a this end part of will be there. No, that one foramen cecum of tongue. Okay, so based on that, if in case any abnormality, mass and cyst is there, means based on the anatomical part, they will denote and they will do the procedures. Okay, then next to that, based on the teeth, it will be divided into four quadrants, that quadrant 1, quadrant 2, quadrant 3 and 4. So upper right, upper left, lower right, lower left, like that they will, that teeth dividends they will do. Okay, then uh, tonsil and adenitis. So tonsil and adenoids means that is anatomical part. It is a backside of the tongue. It will be, so they have given an image of this place. It is tonsil and adenoids means that is a mass like of tissues present in the that backside of the tongue. Okay, so it is like lymph nodes, glands, like that only. So how it will be that lymph nodes, glands and all are located in the neck, groin, armpits area. Like that only, this also will be there. If in case that tonsil or adenoids got infections or some other abnormality, it gets inflamed and it will make a that difficulty to breathe, means inhale the air, it will be difficult, and while talking also it will be it will affect the um, speech capacity also. Okay, so that one we should be treated. So for an example, this one normal adenoids structure they have given. Okay, means a normal tonsil. So this one inflamed tonsil, so it will block the whatever swallowing or whenever we are talking, in that time and all it will make a pain. Okay, so they will remove that inflamed tonsil and they will correct it. Like that only adenoids also, you can see the that adenoids will be there. Here also it will get inflamed and it will make the pain. Then next to that, esophagogastroduodenoscopy. Duodenoscopy means they will see the duodenum by the scopy. Gastroduodenoscopy means the gastric part and this duodenum part they will take the image by using the scopy. That only they have given here. So EGD means esophagogastroduodenoscopy, which means from through the esophagus they will take the image for the gastric and duodenum and esophagus. Okay, so this by using this they will take the image, they will get the image of this esophagus, gastric part and the duodenum part. If in case any infections or inflammations or any ulcers, those and all is there, means they will check by this method and they will take the image and they can redo the biopsies as well. And some other for the procedures also they can use this scopy. Okay, so they have given a one example. So question they have given. So in the digestive part, some questions will be there. That one they have asked here. Is submucosal injections a required component needed to assign a endoscopic mucosal resection? So for the EMR procedure, they are asking this submucosal injection required or not. CPT code for ligation assisted EMR. So the answer is no. Submucosal injection is not required component of the codes for the digestive system endoscopy with EMR, which means that a sigmoidoscopy flexible. That are flexible with the endoscopy mucosal rejection, this CPT, and this colonoscopy flexible means 45390. This is with the endoscopic mucosal resection. So we have to check based on the CPT what is the procedure done, and what is inclusive, those and all we have to check. Then coding for EMR procedures requires the performance of following components. So they have given one by one. So first one, a technique to lift the lesion and a demarcation of the lesion, often by creating the pseudo polyp outside or any techniques, including high definition, white light, narrow band imaging, or by cautery. By cautery means that but electric machines using that they will remove that abnormality. That allows clear visualization of the boundaries of the lesion and endoscopic snare resection. These three techniques they are using. Okay, and if all the three components listed above are not performed, it is not appropriate to report the EMR procedure. So rather specific services performed, submucosal injection, example 45390 snare polypeptectomy, example 43217 is reported with the modifier 59 secondary procedure when biopsy is performed on the same lesion EMR, the biopsy is not reported. Likewise, ablation edges of the lesion, clipping of the defect, other bleeding treatment applied the same lesion are not reported separately. So along with that EMR procedure, these are the procedure we should not bill, that one they have given here. Okay. Then next one, ERCP procedures. Like that only. That is for esophagus and gastric part and duodenum part they want to see means they will do that EGD. If they want to see about this liver and the pancreas, gallbladder, these and all they want to see means they will do that ERCP procedure. ERCP means endoscopic retrograde cholangiopancreatography. So you can see by using the endoscopy, retrograde means backside image. Okay. So by using the endoscopy, backside image of the cholangiopancreatography. Cholangio means gallbladder, pancreatography means pancreas they will see. Okay. So it is specialized minimally invasive procedure combining upper endoscopy and X-ray fluoroscopy to diagnose the treat the condition while an pancreatic duct. Okay, so it is to use to remove the gallstone, open strictures, and place stents for the obstruction. How they will do means by using that endoscopic machine, they will take the image of this bile duct, gallbladder, and the pancreas. Okay, so they have given what is the procedure they will do. So it is a thin, flexible tube with using the camera. They will take the image of the mouth, esophagus, stomach into the small intestine. A catheter pass through the scope injected by the dye allowing X-ray visualization of the duct. Okay, so they by using this scope, they are taking these images. Then next one, colonoscopy. In the surgery part, this is a very important part. They will do this colonoscopy. Some difference between this diagnostic procedure and therapeutic procedure. We have to be more careful on this. Okay, so for this colonoscopy, we have to see that colon structure. Uh, 1 minute. You are able to see my screen, right? So in this diagnostic procedure, therapeutic procedure,
Yes, I'm able to
some
see. Mm.
anatomical part is same only. So diagnostic procedure they will do for the diagnostic purpose, therapeutic procedure for the treatment purpose they will do. But the anatomical part of the colon they will denote that how much procedure they have done we have to decide. Okay. So for an example, first one does not reach the splenic flexure. Splenic flexure means, the descending colon is there, right? So they will send that colonoscopy from the anus. It will reach the rectum and it will reach the sigmoid colon. So in this So in this part, from the anus, rectum, this is a sigmoid colon, right? So this is a descending colon. If in case it is reached the splenic flexure, this place is called as a splenic flexure. So if that is a splenic flexure, and this is for this is a cecum bone, this is a cecum colon. So that and all we have to check. So how much it is reached, based on that we have to give the CPT. So this is a transverse colon, this is a ascending colon. So you can see they have given a CPT. First one does not reach the splenic flexure means from the anus to rectum and it will reach the sigmoid colon. It is towards the splenic flexure but not reached the splenic flexure. In that time, we have to consider that is a flexible sigmoidoscopy. If it is done for a diagnostic purpose, we have to use the CPT 45330. Okay. So next one, beyond the splenic flexure but not to the cecum. So they crossed the splenic flexure. They have seen the transverse colon but not reached the cecum. So near to the appendix they didn't see. So only transverse colon they have reached means in that time we have to use the CPT for the diagnostic code 45378 with the modifier 53. When we will use the 53 modifier, it is a discontinued procedure. So the procedure started, but it is not completed. Okay. And to the cecum, if it has reached the cecum, we no need to add the modifier 45378 only, we can go. Okay. This is for diagnostic purpose. Like that, treatment purpose also, same like if it is started and it is not reached the splenic flexure means flexible sigmoidoscopy, the CPT series will be 453312, 45347. And beyond the splenic flexure but not to the cecum means the CPT series with 52 modifier. 52 modifier means half payment. Okay, reduced service. Then it reached the cecum means colonoscopy codes, no need to add the modifier, the same CPT series only. We have to add 453792, 45398. Okay, then next concept is screening colonoscopy. When they will do the screening, if the patient doesn't have any abnormality, there is no any symptoms, for the screening purpose they are doing, means in that time we have to use the screening code. So report a screening colonoscopy for a Medicare patient, we have to use the CPT G0105, which means colorectal cancer screening colonoscopy on individual at high risk. And G0121 colorectal cancer screening colonoscopy an individual not meeting the criteria for high risk. Okay, these two CPT series we have to use. So for the Medicare beneficiary without high risk factor are eligible for the screening colonoscopy every 10 years. Then beneficiary at high risk for developing the colorectal cancer are eligible for only 24 months. Okay, if in case high risk means every 10 years, without high risk eligible only for every 24 months. Okay, then for without high risk means every 10 years, with the high risk means every 24 months. So 24 months means every 2 years. Okay, then Medicare consider a individual high risk for developing colorectal cancer as one who have one or more following criteria. So that one, what are the high risk they are telling? So first one, a close relative, which means siblings, parent or children who has had a colorectal cancer or adenomatous polyp. is there means that is considered as a high risk. Then a family history of familial adenomatous polyposis. Then family history of hereditary non-polyposis colorectal cancer. Then a personal history of adenomatous polyps. Then a personal history of colorectal cancer. Then inflammatory bowel diseases, including Crohn's disease and ulcerative colitis. These all conditions considered as high risk. If patient has a high risk, we have to consider that it's a we have to do the screening for every 2 years. Okay. The screening test is a provided a patient and absence of sign or symptoms based on the patient's age, gender, and medical history and family history according to the medical guidelines. It defined by the population and which test is performed, not the result or finding of the test. So, not based on the result. They are having this possibilities means based on the age, gender, medical history, and family history. They are doing this screening study. Okay. Then that clinical scenario they have given. So a medical patient with a history of Crohn's disease presents for the screening colonoscopy. Her most recent screening colonoscopy was 25 months ago. No abnormalities are found. Reportable procedure and diagnosis include. So CPT will be G0105 colorectal cancer screening colonoscopy on individual at high risk. And the ICD will be set 12.11. This should be coded primary for this screening study. Encounter for screening for malignant neoplasm of colon. Then that Crohn's disease. So Crohn's disease of the both small and large intestine without complication. That and all we have to give. Sometimes if they have a personal history, family history means that codes we have to give. So personal history of the other malignant neoplasm of large intestine, personal history of other malignant neoplasm of rectum or rectosigmoid junction and the anus. Then family history of malignant neoplasm of digestive organ and personal history of colonic polyp. These and all is there means that one we can give. Those are high risk. Okay. Then screening colonoscopy for the non-Medicare patient, how we have to code that one they have given here. So when reporting a screening colonoscopy, non-Medicare patient reports CPT 45378 and use the appropriate screening diagnosis code as a result of the American Healthcare Association. Okay. Then patients covered by the group insurance policy that was purchased or renewed after September 2010 will have no copay or deductible unless the plan applied for the grandfathered status. Okay. Then that clinical scenario 3 they have given a 52-year-old patient calls the surgeon office and requests the screening colonoscopy. The patient has never had a screening colonoscopy and patient has no history of polyps and none of the patient's siblings, parents, children has history of the polyp or colon cancer. The patient is eligible for a screening colonoscopy. Reportable procedure diagnosis code is 45378 and is at 12.11. Okay, that is a screening code we have to give it. There is no risk and all, so no need. Then modifier for PT, the CMS developed the PT modifier to indicate the colonoscopy was scheduled for the screening was covered the diagnostic or therapeutic procedure. The PT modifier, which means colorectal screening test converted to diagnostic test or other procedure is appended to the CPT code. So like the patient started with a screening, but they have seen the abnormality and it is converted into the diagnostic means in that time we have to use the PT modifier. Okay, add modifier PT to the CPT codes above indicate that scheduled that screening colonoscopy was converted to diagnostic or therapeutic. Okay, so in the time modifier PT should be added to the anesthesia service as well. And this informs Medicare that it was service performed for the screening and patient will not be charged and deductible. Then there will be a copay due. Then screening colonoscopy for non-Medicare patients that becomes the diagnostic or therapeutic. That one they have given here. When screening colonoscopy is converted to diagnostic or therapeutic procedure for the non-Medicare patient, the surgeon must document that the intent for the procedure was screening in order for the patient's insurance to process the claim without out-of-pocket expense in accordance with the ACA. CPT developed the 33 modifier for the preventive services when the primary purpose of this service is delivery and evidence-based service in accordance with the US Preventive Service Task Force A or B rating in effect and other preventive services identified preventive service mandates, which means that is legislative or regulatory. That service may be identified by the 33 to the procedure. For an example, the surgeon performing the screening colonoscopy find and remove the polyp with a snare. So use CPT code 45385 and append 33 modifier. So it is converted to from the screening to treatment. So they want to remove the polyp. So they have to add the 33 modifier. Okay, this is for a non-medical. Then clinical scenario 4, the same 52-year-old patient with the previous example has had an abnormal finding during the screening colonoscopy. The surgeon removed the polyp with the snare technique, reportable procedure and diagnosis code. That only, so they are adding the same CPT 33 modifier, that screening code and polyp of the colon we have to add K63.5. Okay. So they have given a question on question to that question on for related to the sequencing, how we have to code. So test if they are performing that screening study and the polyp found means screening code should be primary followed by polyp code we have to use. So any condition present found in the screening study means first screening code followed by any abnormality present. That only they are telling in this question 1. That is a sequencing. Okay. If in case they have a history code means family history, personal history means that will be followed by the that this abnormality code. So if in case they are coming for the follow-up visit means if the polyp is removed means that the polyp code no need to code. That only they are telling. The remember that once the polyp is removed, the patient follow-up visit should not be coded the polyp code. So we have to use the personal history of the polyp code we have to use. Okay. Then next to that, surveillance colonoscopy. What if it is a surveillance colonoscopy for 4 years later? Then what diagnosis coding is used? So can I still use the screening code on the claim form or only history code, personal history of the colonic polyp? If can use both, is there a rule about sequencing? So they asked the question. Okay. So for that question, they have answered. Sorry. Words that physician may use the screening colonoscopies include screening, surveillance, preventive, high risk screening, average risk screening, need for screening. In this case, since the word surveillance colonoscopy documented, I would recommend coding the screening followed by any findings as well as personal history of the colonic polyp, which means once treatment done and that time if in case they are doing that screening means screening code should be primary, then followed by history code we have to use. That only they are telling. Then next one, anal fistula. So they have given a anatomical part of this anus. Okay, so how it will be? Then extrasphincteric. This is a extrasphincteric area, and this is a suprasphincteric area. Then transsphincteric area. Then intersphincteric area and a submucosal area. Okay, so it may lead that fistula in these places. So in the uh, this slide, you can see the what is fistula, what is pile, what is the fissure. You can check. See, this is a piles mean it is like a hemorrhagic lumps will be there. Hemorrhoids will be there. That hemorrhoids may be occurred in the inner side of the anus or outer side of the anus. Okay. Then anal fissure means it is like a cracks in the anus. Okay. So because of pressure, it may lead to that some cracks. This is a anal fistula. And sorry, this is a anal fissure. Okay. Only cracks. But anal fistula means some openings will be there because of pressure, not from this anus area, nearby that sphincter muscles and all is there, right? These places, some openings can happen. That is fistula. Okay, so you can see this is a that buttock muscle area. So in this place, some opening happen and it may make some infections, bleeding, those and all will happen in this fistula. Okay, this is a fistula. Means ulcer means some ulcers can happen in the rectum area. That is a ulcer, anorectal ulcer. So now you can understand the what is the piles and what is the fissure and what is the fistula. Then Satan placement means for the fistula, they can place some this Satan. Satan means it is the thread like rubber bands they will place. So it will that control this opening. Okay. So if in case if we are leaving like this means that fistula, it may make some abscess, then infections, some other abnormalities. To avoid that, they will make like this treatment. Next concept is okay. Next concept is hernia. Hernia means it is like some bulges happening in the stomach area, lower abdomen area. In these places, it will happen because of some pressure. These muscles get damaged. Some tears happen because of that. That internal organs and the internal parts will trying to come out in this muscle area, like that only this will get appeared. Okay, so sometimes it may be a problematic or sometimes it won't cause any symptoms or any abnormality, just this appearance only will be there, like small lumps or small masses, like that structure only they will give. So based on the anatomical part, that hernia name will be differ. If it is occurred in the epigastric area, it is epigastric hernia. If in case it is happen in the ventral muscle area, that is ventral hernia. If in case occurred in the umbilical area, that is umbilical hernia. So umbilical hernia means some people their umbilical area only will get a ball-like structure. So that is a umbilical hernia. Then Spigelian hernia, it will be side of the umbilicus. Then next one, inguinal hernia. So that only they have given here images. Inguinal hernia, then below the umbilical area, incisional hernia will be there, and then femoral area, if it is happen, means that is a femoral hernia. That hernia will happen because of sometimes the patient holding heavy weight. If they are lifting the heavy weight, they are giving the pressure to the abdominal area, they may get this hernia because that abdominal area muscles will get tear, that intestinal part will trying to replace this tear area and it will make a bulge. Sometimes that intestine, if it is coming with this hernia means it may get blocked and it may get infection and it may get burst, and it may lead to the severe level like a death. So that is should be treated. Okay. So you can see that calculating the measurement of the hernia they have given here. So totally, whenever we are coding hernia treatment, how they are going to calculate means total length of the hernia they will measure. If in case only single hernia means like that they will remove, means only one hernia is there. So total length of the hernia size, which one is a highest level, with like if in case oval shape means that breadth sizes will be less, length size will be more. So that length size only they have to calculate, and the total length they have to calculate. If in case multiple hernia is there, but while removing that multiple hernia treatment, in that time, if multiple hernia is there, their distance from one hernia to another hernia less than 10 centimeters means we have to add that total length, like in this totally three hernia is there. So for this hernia and this hernia, 0.5 centimeter distance is a gap is there, and this hernia to this hernia 3 centimeters gap is there, means how we have to calculate, we have to add this total length of the hernia, which means we have to add this hernia length along with that these 3 centimeters, and this hernia length along with that 0.5 centimeter length, and this centimeter this hernia length, like that we have to add. So we have to calculate like that only. If in case, if they are removing only two hernia, three hernia, but that difference between the hernia 10 centimeter or above means we have to calculate the length based on the individual length only, not together length we have to calculate. Okay. So individual length only we have to calculate. You can see the image. This one, the length between that hernia, it is less than 10 centimeter. So we are adding. But in this two hernia, distance is 10 centimeter or above 10 centimeter means we cannot add together. This one 5 centimeter length and this one 2 centimeter length means totally 7 centimeter only we have to calculate the total length of the hernia. Okay. Like that only we have to calculate the hernia measurement. So here, the for what are the guidelines we are following for the hernia, they have given here one by one. We can see one by one. The type of the hernia is no longer a factor in coding, which means what is the type of the hernia? It may be a epigastric hernia or ventral hernia or umbilical hernia. That is not a matter. We are calculating that is hernia. So the new codes remove reference to specific type of the hernia such as ventral, umbilical, epigastric, spigelian or incisional, or instead of the single term of the anterior abdominal wall hernia. So in some ways this makes coding easier. For an example, we can skip scrutinizing and operative report trying to determine the hernia umbilical or ventral, because there is a supraumbilical extension. It's all same code. So that time we no need to see the type of the hernia. It's with that said, documentation should still list the type of the hernia in these terms for the best practice, just from the pers perspective of having complete note with the good clinical details. But you could still code the hernia repair if you have the documentation minimally support the anterior abdominal wall hernia repair. Okay. Then next, one hernia repair code per surgery. If there are multiple anterior abdominal wall hernia defects, one umbilical hernia and one incisional hernia. So you would code one CPT for repair of the all defect combined, even if separate incision required, because we have the rule of one code per surgery for any number of the anterior abdominal wall hernia repair. So they are telling, if in case one umbilical hernia, one incisional hernia is there, means how we have to consider, like that they are telling. So in this scenario, they are telling one code concept only we are following, like coding, if nearby hernia is there means we are adding and coding, right? That like that policy, one code per surgery, that one we are following. Then for any number of anterior wall abdominal wall hernia repairs, if some hernias are reducible, um, and some are incarcerated during the same surgery, code their repair as incarcerated with a single CPT code. More on that below under item 4. So they have given in the detailed explanation in the fourth one. Okay. Let's note parastromal or inguinal or femoral or lumbar hernias are not subject to the rule and can be coded separately with their own CPT code when performed. So for these four one, we have to use the separate codes. No need to add the combined code. One code per surgery. That one, no need. So what is for this repair concept? Okay. Then next one, open versus laparoscopic approaches are treated at the same. Means whenever we are coding both, we are doing both in that time. For an example, they will start with that laparoscopic approach. It is not supporting. In that time, it will convert it to the open. So how we have to use that one they will give. If in case they have started with the laparoscopic, laparoscopic means laparoscopic code, we have to go. Open means open code, and robotic assisted approach means that one we have to go. If in case some scenarios laparoscopic approach is started and it is converted to open means no need to code the laparoscopic. We have to consider that as a open, that laparoscopic is considered as a failed procedure. Okay. Then mesh insertion bundle. Mesh insertion means that hernia how they are treating. So that muscle is got tear, so colonist came out. So how they will treat? It may be a open or laparoscopic or robotic. They will open procedure means they will open that place. They will push that colon towards inside part. Then they will, if necessary, they will place the mesh and they will tie with the repair. If in case laparoscopy means same they will do. So they will insert the colon and if needed, they will place the mesh and they will seal it like that only. So CPT 49568 has been, it is deleted. So because for that mesh insertion. Okay. Now that a new hernia repair code when performed. So this means there is no separate code for the mesh replacement, sorry, mesh placement for the ventral and incisional hernia repairs, which have historically permitted mesh insertion and additional code. This is also mean that you report the same CPT code whether mesh is inserted or not. So which means that CPT inclusive that mesh insertion. Previously we are coding separately, but it is not coding now. Okay. Total length of the hernia defect. So this perhaps the biggest change for the hernia repair coding in the 2023. You now code the single CPT for all anterior abdominal wall hernia repairs based on the total length of the defect. The CPT codes are written to the report repairs of the hernia defect that are less than 3 centimeter, 3 to 10 centimeter or greater than 10 centimeter reflect the different level of the surgical work required the repair of the various hernia. So how we have to follow that hernia repair only they are giving. Okay. So again, you report one code from the CPT range, these CPT codes entirely, regardless of the number of anterior abdominal wall defect. More than below under tips accurate measurement. So this one explained in this accurate measurement topics. Okay. So that were tips we can see. First one, measure the hernia defect before opening the facial defect from the pre-op CT scan. So the hernia defect we have to calculate first. Then once tissue is incised, fascia can retract because once that opening happen means it may expand. That's why before doing opening we have to calculate, causing defect to appear length than is accurate. So total length of the defect is taken maximum width or height if you drew or oval around perimeter of the hernia defect. Already I told. So which one is the highest length of that particular hernia? That one should be calculated. Then for a Swiss cheese defect, which means multiple defect separately by very small areas where the fascia is intact, giving the fascia appearance is Swiss cheese. So multiple areas it is got affected means how they are considered. That one they are telling Swiss cheese defect. Measure the superior top of the edge of the uppermost defect and the inferior part of the lower defect of the total lentil fan. I told right the three hernia image I have explained right like that only. So which one is the topper one and which one is the lower one? That one we have to calculate. Then if there are multiple defects separated by the 10 centimeter or greater than intact fascia, measure each defect individually and add the size defect together to the report single CPT for the overall repair, but do not count the intervening intact fascia in the measurement. This one we already explained. In between the hernia, 10 centimeter or greater than is there means we have to individually calculate and we have to give the code. So they have given example. For an example, if there is a supraumbilical defect is 3 centimeter and incisional hernia along the brayer, prephalangeal incision measuring 6 centimeter and with 10 centimeter intact fascia between them, the total defect coding purpose is 3 plus 6 centimeter for the total of 9 centimeter because in between 10 centimeter gap is there. Okay, understood, right? Next. In contrast, when defects are separated by less than 10 centimeter, so of intact fascia in the Swiss cheese defect example, total measurement from the uppermost to the lowermost defect inclusive of intact fascia is counted. So first we explained right those three different hernia is there, but in between less centimeters only is there. So for that they have given an example. So if there is a 2 centimeter defect, then 3 centimeter intact fascia, then another 2 centimeter defect, 2 centimeter intact fascia, and final 2 centimeter defect. Your total measurement for coding purpose is first 2 centimeter and fascia 3 centimeter and intact fascia between defect 1 and 2 centimeter and that intact fascia between defect 2 and 3, then 2 centimeter for third defect. So totally 11 centimeter. Okay. So removal of non-infected mesh. So sometimes the mesh placed, some place it may get infection and they will replace. Sometimes patient itself they want to remove the mesh. Now they are okay. They want to remove the mesh means we have to use the CPT 49623. Okay. So for removing that mesh, we have to check this one. And if for infected mesh removal, for that specific code will be there. That one we have to use. Okay. So 49623 is the add-on code that may be reported any of the new hernia codes from the these CPTs. Then half note, infected mesh removal is still coded with the CPT 11008 in 2023. So this is a digestive system part procedures explained. So I hope everybody understood.